and welcome to our Healthcare Careers and Focus session. My name's Chloe. Today I have got Jessica, who is our podiatry specialist, who is going to talk to you all about podiatry. Thank you, Jess.
Hi, thank you, Chloe. My name is Jess. I am a diabetes specialist podiatrist, and I am based in the diabetes foot clinic at the North Norwich Hospital. So I'll talk a little bit about myself and my career journey and about my job. So straight after school, when I finished my GCSEs, I went to sixth form to do my A-levels. I didn't know what I wanted to do career-wise at this point, but I chose fairly sciencey courses. So I did human biology, PE, and psychology. At this point, I think I knew that I wanted to do something in healthcare, but I wasn't too sure what. I always thought that I'd probably go down like the nursing route or midwifery. And then when I was in my second year at sixth form, they start pressuring me fairly early on into applying for like UCAS and university. So I had to make a decision, and it was the only reason I really thought about podiatry was because when I was younger, I actually saw a podiatrist myself, like ingrowing toenails. And I think it was my mum that actually suggested podiatry. Why not? And I think one of the quite attractive things about podiatry is that the job tends to be 9 till 5, and you can either work. I mean, there's lots of scope in podiatry, but a lot of people work either in the NHS or privately. So you can have your own business, like plan around children, that kind of thing. So I did some shadowing at a local podiatry clinic and decided, yeah, that's what I wanted to do. So I studied podiatry at the University of Southampton as an undergraduate degree. And when you finish at university, you're fully qualified as a podiatrist. You register with the HCPC straight away, and then you're good to go and apply for your first job. So my first job was as a community podiatrist in Cambridgeshire in 2013. And that's where my family were based. So I moved back home for the job. So working as a community podiatrist, I was working mainly in like GP surgeries, local like community hospitals. And I think I knew at this point that I wanted ultimately to work in an acute setting, like in a hospital. When I was at university, you go into placements, and one of my placements was in Singapore. And that was a hospital-based placement, and I absolutely loved it. And I thought, yeah, that's what I want to do at the end of the day. And I saw this job as the Diabetes Specialist Podiatrist advertised. I applied for it, and I got the job in 2016. And that's where I am now. So I've been there ever since. And since working here, I've done extra courses. I finished my postgraduate diploma a couple of years ago, and that was called Lower Limb Preservation in Diabetes, so totally specific to the job that I'm doing. And that was at the University of Ulster. So a little bit about podiatry. So a podiatrist is a healthcare professional that specialises in the management of foot problems, so foot, ankle, and the lower leg. And they can work in lots of different settings. I would say the majority of people work either in the NHS, so in hospitals, or in the community, or in private practice. Either for themselves, so working as part of their own business, or working for somebody else. There are lots of other places that you can work though. So the Ministry of Defence is one of them. You can work in like sales and marketing, education, so teaching podiatry at the colleges, at the universities, or research. And research is actually something that we are actively involved in here at the hospital. So podiatrists manage lots of conditions, so basically anything and everything to do with the foot, really. So there's like skin and nail problems, foot problems that are caused by diseases such as diabetes, rheumatoid arthritis, and vascular disease. They can all affect the feet. Musculoskeletal problems, so problems that affect feet that can cause a lot of pain. So in my old job as a community podiatrist, we assess patients with foot pain. We would prescribe them orthotics, so insoles, and give them stretching exercises to do. Podiatrists can treat sports injuries, and most professional big sports clubs have a podiatrist that works for them. You can work in forensics, which is quite a small area, but it sounds very exciting, and foot surgery as well. So my job is just with diabetes. So all of our patients have diabetes, and diabetes itself can damage the nerves and the blood vessels in the feet, causing quite serious foot problems. So when the blood vessels are not working properly and the blood can't get to the feet, this can cause problems. Diabetes also affects the nerves in the feet, and when they become damaged, patients can't feel their feet properly, and then this can lead to problems as well. And the combination of both blood vessel problems and nerve problems can lead to diabetic foot ulcers, gangrene, and quite a rare complication of diabetes, which is called Charcot. So they are the three main problems that we treat here in the Diabetes Foot Clinic. So based in outpatients, but we work both outpatients and also inpatients on the wards at the hospital. So a general day for me here at the hospital. So at 8 o'clock we have like a team huddle. So we kind of dish out all of the different jobs, like who's going to do what, who's going to be in clinics, who's going to be on the wards. We do quite a bit of teaching here as well. So I might go onto the wards to see inpatients. So some people need to be admitted into hospital because of their foot problem. So they might need antibiotics, or they might need to see a surgeon. So those patients would be referred to us, and we would go and assess and see them on the wards. But sometimes patients get admitted into hospital with other problems, completely nothing to do with their feet. But when they're in the hospital, it might be identified that they have a foot problem. And in that case, they'll be referred to us, so we would go and assess and see them. We do quite a bit of education in the hospital. So we go and speak to ward nurses, the healthcare assistants on the wards. We do some outpatient teaching as well. So we talk about diabetes and how it affects the feet, specifically to people that work on the wards, things that they could be looking out for, things that they can identify in patients that have diabetes, and when to refer them to the Diabetes Foot Clinic. We do a lot of tests here in the foot clinic. So on a normal day, I would check the system that we have all of our reports go to. So I would check action and sign off blood tests, X-ray results, swab results. So I would look at the result, decide what needs doing, if we need to take any action, and then sign them off. Have lunch, and then in the afternoon, we would often spend time in clinic. So we would be seeing outpatients. And our outpatients come in with various foot problems, the main ones being diabetic foot ulcers, and then people with gangrene, so circulation problems, and Charcot, which is a very rare complication of diabetes, but it's where somebody can present with a very red, hot, swollen foot. And the treatment for this condition is to immobilise the foot, which is where we put them into a cast, like a plaster cast, similar to when, for example, you might break a bone. So yeah, that's just a general kind of overview of what I might do in a day. So the Diabetes Foot Clinic is led by podiatrists, but we work as part of a multidisciplinary team. So we work alongside lots of other specialties. We have a consultant diabetes doctor, and he kind of leads and overviews the Diabetes Foot Clinic. We work alongside vascular surgeons, because quite a lot of our patients have circulation issues. We work alongside orthopedic surgeons that might see our patients if they have non-healing bone infections, or they need some kind of reconstructive surgery to their foot, or for amputations, they might see either an orthopedic or a vascular surgeon. We work very closely alongside the diabetes specialist nurses. So a lot of the patients that we see in the foot clinic have either had diabetes for a long time, or their diabetes might not be very well controlled. So they need lots of input from the specialist nurses. We work alongside an orthotist. So every Wednesday we have an orthotist that works with us, and they They see our patients to get them measured up for either specialist footwear or orthotics, which is like an insole that can go inside their shoes, to help offload the pressure from a foot ulcer, for example. We also work alongside microbiology. So they have a look at all of the tests that we do when we do swabs and tissue samples to try and identify what bug is causing an infection. Radiologists we work with day to day, so lots of our patients need x-rays, and the radiologists look at the x-ray scans to see what issues are going on with the bones, which is mainly bone infections, which is the thing that we tend to refer patients for x-rays for. And we work alongside GPs as well. So lots of our patients need antibiotics, so we often initiate the antibiotic treatment, and the GPs often prolong the course if needed. So there are loads and loads of rewards of working of this particular job in podiatry. I'd say one of the main ones is building a really strong relationship with our patients. So we see our patients on a really regular basis. They tend to see us really quite frequently, either weekly or fortnightly, because they need quite intensive treatment to try and get their foot healed. So that's definitely one of the real benefits of this job. It's really nice. We get to know the patients and their families really well. Obviously, one of the main rewards is seeing their foot problem heal. So from the moment they come in to see us and they've got quite a bad foot, we can get them to a point where their foot heals and we can discharge them. Then that's obviously brilliant. A reward is being a specialist in our field. So podiatry it's really quite a small profession. Not that many people know about it, or they might have heard of a podiatrist but not really know like the ins and the outs and all of the different like scopes within podiatry. So podiatry is quite a small profession, but when you think about the diabetic foot, that's an even smaller field. So being a real specialist in what we do is really good. We give a lot of advice to other professionals, so doctors and nurses. We advise them, we give treatment plans, and we advise them on what the patient needs in order to get them better. We give a lot of advice to obviously the patients and their families and their carers when they come in. A great thing is we have colleagues from all kinds of specialities. So like I said in the slide before, we work alongside different types of doctors, nurses, other allied health professionals, GPs. And also we are the gatekeeper for our patients. So patients come in, so on the initial appointment they'll be booked in to see ourselves, so a podiatrist. And when I say we're the gatekeeper, we decide kind of what needs doing and what specialist clinics the patient needs to be booked into. So we will see them and we will signpost them to the particular consultant that they might need to go and see. So we are kind of right in the middle of their care and in their treatment, obviously the patient being involved all the way along. But we are, as podiatrists, we are the ones that book them into specific clinics and advise on what we think needs doing. Of course, with the benefits comes challenges, as it does with all jobs. So the days can often be quite busy. It's completely impossible to predict what's going to come into the clinic. So with new patients, you can read a referral, but you never really know what's going to come in and what's going to present until you've got the patient sitting on the couch in front of you, and after you've assessed their foot. We might put the patient in for a follow-up review with the hope that when we see them in a week's time, things are going to be looking a little bit better. But sometimes this isn't the case, and they come back and things are quite a lot worse. This can sometimes lead to the clinics overrunning. That can't be helped at all. But days can sometimes be stressful if you've got like multiple patients that come in with foot infections, and then there's lots of extra things that you're doing. So you need to sort out swabs, x-rays, get antibiotics for them. So sometimes clinics can overrun. But we're a team of 7 podiatrists here, so there are always kind of people in the room next door, and we just kind of muddle through together, to be honest. We haven't got a set clinic for each podiatrist. we tend to have either 2 or 3 clinics running at the same time, with several podiatrists in a different room, and we literally just get whichever patient is waiting next. So you're not allocated to a set clinic, if you like. We all do the same thing. A challenge of the job is amputation. So the main goal of our job is to prevent amputation. So that is something that all of our patients are at risk of. Sadly, this sometimes does happen. Patients sometimes need toes amputating. Occasionally, it ends up being further up, so that they might end up needing to have either a below or a above knee amputation. That's, like I say, what we like. Our ultimate goal is to try and prevent that, but unfortunately, sometimes that does happen. A challenge would be unwell patients. So a lot of our patients are quite generally unwell. If they're coming to see us with a diabetic foot problem, the chances are they've had diabetes either for quite a long time, or the diabetes is quite poorly controlled. If they've got poorly controlled diabetes, there's quite a high chance that they're going to have other health problems like cardiovascular problems, renal problems, so kidney problems. So lots of our patients are quite generally they're poorly, but some of them are quite poorly patients. And sometimes if they come in with a foot infection that's not being very well managed, they might come in actually very unwell because of their foot infection. And sometimes have to admit them into hospital to try and get on top of the infection if oral antibiotics are not going to work. And that can sometimes be quite a stressful situation if you've got a patient and outpatients, and you need to get them a bed on the ward. So the wards are very busy. Beds are can be quite difficult to come across. So there's lots of liaising with like the doctors, the bed manager, the wards. But it's also really exciting. That's a really exciting part of the job. Another challenge would be having to think outside of the box. So not all patients come in with a foot ulcer are going to respond to the same treatment. So we can give what we call the gold standard treatment. They can have, you know, the right, all of the right care, but sometimes they don't heal, and we just need to think actually what's going on that we might not be thinking about. Like there's always things at the back of our mind that we need to be thinking, hold on, is this going on at home? Is the patient doing this? Is the patient doing that? Or maybe this is going on and the patient's not aware. So you really do have to think outside of the box, I would say. So I've got a little case study for you here. So infection complicated by osteomyelitis. So osteomyelitis is the technical word for bone infection. So this is a patient that we were treating several years ago, and is quite typical of the patients that we see day to day. So this lady was 43 years old. She has type 1 diabetes and has had it for 10 years. Other health problems include depression, IBS, and diabetic retinopathy, which is eye disease, which is caused by diabetes. So the patient had very poorly controlled diabetes. She had palpable foot pulses, so that means that she has a good pulse in her foot, so we can feel the pulse using our fingers. That would suggest that her circulation down to her feet is very good, which is obviously a great thing. But she was what we would call neuropathic, so she has nerve damage in her feet, so she can't feel her feet. So it's neuropathy is quite a difficult thing to explain unless you've got it or you know somebody that's got it. But when the nerves are damaged, you literally cannot feel your feet. They can be completely numb, sometimes not completely numb. But it's extremely easy then to get a problem. So a blister or a wound, or it's easy to step on something and not realise at the time because you've lost that protective pain sensation. So this lady attended an annual review with one of the diabetes doctors, so a review of her diabetes, and presented with an ingrowing toenail in her big toe. So the doctor has seen the ingrowing toenail. They've asked one of the podiatrists to come and see her, ask if we can treat it, which of course we have done. And she's presenting with a soft tissue infection. So the toe is quite red, it's quite hot, it's quite swollen. So we give her antibiotics. When we've assessed the lady, there's a very small sinus, so a very small hole around the edge of the nail, which is probing to bones. We put a very small sterile probe into the wound, push it down, and it hits the bone straight away. So that would suggest that it's not a superficial wound, it's actually very deep. We send a sample of pus off to microbiology to see what particular bugs it was growing, to make sure that the antibiotics that we give her were going to treat the infection. So we booked her in for a follow-up review 1 week later. And when she comes back a week later, she tells us that she's been feeling quite lousy and quite unwell for the past 2 days. So to us, that's a bit of a red flag. It makes us think, oh my goodness, why are they feeling unwell? Is it because of their foot? And in this case it was. So socks and shoes off, have a look at the foot, and it's significantly deteriorated. So the whole foot now is red, hot and swollen. It's not localized to the toe anymore. And we're thinking, okay, this lady's got a very serious foot infection. It's not being managed with the oral antibiotics. She needs to come into hospital. So she had a very high pulse rate. So when patients are coming in with infections, we do a full set of observations. So her pulse rate was very high. But other observations like her blood pressure and her temperature were normal. But a very high pulse rate, and clinically looking at the foot, we were thinking, okay, this lady needs to come into hospital. So she was admitted under endocrine, so under the diabetes doctors. We ran some bloods on her, and her infection markers were high, suggestive of an infection. She was started on intravenous antibiotics, and she would have had an X-ray on the day that she was admitted, and this has shown that there is a small area of bone infection. So we see her 3 days later on the ward. So every Tuesday morning we have a multidisciplinary diabetes foot ward round. So we go around to see all of the patients that have been admitted into hospital with a bad foot. So there's podiatrists, we go with a diabetes consultant, we have a vascular surgeon, orthopedic surgeon, basically the whole team. Great news is that redness to the foot and the swelling is much, much better. So she's responding really well to the intravenous antibiotics. But we decide that she needs to stay in hospital for a little while longer. So just a bit of a kind of Q&A for you, or what test do you think might we need to do when treating an infection? So I've gone over some of them, but we can think about things like blood tests, scans. So this lady's already had an X-ray. We can think about other scans. So X-rays sometimes don't show up bone infections straight away. Sometimes we need to repeat an X-ray 2 or 3 weeks down the line if the initial X-ray is looking normal, but we're still suspicious. In this case, we couldn't wait for her to have another X-ray 2 or 3 weeks down the line, so we could arrange an MRI scan for her. We do lots of samples, so wound swabs or tissue samples. And clinically looking at the foot when we're treating somebody with an infection. So it's not all tests that get sent off to the lab or scans. We're experts in looking at a patient's foot and assessing clinically, what does it look like? Is this infection? Is it not infection? Is it improving? Is it getting worse? So we look at things like swelling, redness, erythema, how red is it? Is it looking really, really angry? Is it smelly? Is there much discharge coming from the wounds? Is it leaking lots and lots? Is the dressing getting really wet really quickly? Things like that we look for as well. So this lady ended up being in hospital for 15 days. Her blood markers were decreasing quite quickly, which was really great news. But she did have an MRI scan, which showed the extent of the bone infection, which was actually a little bit worse than what was shown on the X-ray. So quite a big portion of the big toe bone was indeed infected. And that's the main reason that we decided to keep her in hospital for 2 weeks, to keep her on the intravenous antibiotics. Because bone infections we treat quite differently to skin infections. They need a much longer course of antibiotics. So she had 2 weeks of IV antibiotics, and then when she was discharged home, she needed 4 more weeks of oral tablet antibiotics, so 6 weeks in total, which is the normal treatment or the initial treatment for a bone infection. So when she was home, we were seeing her weekly in the foot clinic, and then fortnightly when things were starting to look a little bit better. And then towards the end of the course of antibiotics, so 6 weeks later, we repeated the X-ray to see what changes were going on with the bone. And great news was that it showed that the bone infection was healing, which was really, really good news. So very, very slowly but surely. So diabetic foot problems often take a very long time to heal. So she was coming in to see us weekly to begin with, and we were doing what we call regular sharp debridement. So one of the things that we do for diabetic foot ulcers is we remove the dead tissue and the dead skin. And the way that we do that is by using a scalpel, which is a very small blade, and we call it sharp debridement. So we're removing the dead tissue. We often make the wound bleed, but only in patients that have good blood supply, which this lady did. And often removing the dead tissue and making it bleed to some extent can help help the wound healing process. One of the other really important things when we're trying to heal a diabetic foot ulcer is offloading. So we like to keep the pressure off these wounds. So most of our patients can't feel the wound, it's not painful. So without any treatment from us, they would carry on walking on their foot, carry on walking on the wound, in which case it's not going to heal. So we prescribe our patients offloading footwear or boots, or we sometimes put our patients into casts, so a plaster cast. And the reason for doing this is it completely immobilizes the foot and keeps the pressure off the bottom of the foot, which is where the ulcer is. This lady was getting really frustrated because it's taking months and months to heal, which is completely understandable. And often when patients have to come and see us weekly, they're having to take time off work if they are in employment. And it can be really frustrating and really horrible for them having a big wound on their foot for a long time. This lady in particular needed lots of input from the diabetes specialist nurses that are in the corridor just around from us. So she was needing lots of input from us, needing her insulin, like titrating, try and get her blood sugars down to a more acceptable level, because good diabetes control is going to help with wound healing. Unfortunately, this lady was a smoker, and smoking can be really harmful to the blood supply. Fortunately, her blood supply was okay, but we were trying to get smoking cessation information across to her and give her support to try and give up the smoking. Even though she has good blood supply at the moment, that's not to say that years down the line things won't start to go wrong, so blood vessels start to narrow and can start to block. And of course, smoking is very harmful for other things as well, so it can cause strokes and heart attacks as well. She refused the smoking cessation information, which is obviously her choice, and that's something that we're quite active in promoting as well. Good news is this healed 3 months later. 3 months might feel like a very long time. It is a long time, but quite often wounds can take quite a bit longer than this to heal. But luckily for her, it took 3 months, and then she was discharged from the Diabetes Foot Clinic, and we referred her to community podiatry. So community podiatry, similar to my old jobs, they're podiatrists that work more locally to where patients live. They would have seen her on a very regular basis, so every, say, 4 to 6 weeks for regular maintenance and general foot care to try and help prevent her foot from re-ulcerating. So that is my little case study. Hope it's been interesting. Let us know what you think. Thank you.
Thank you, Jess. That was really, really helpful, and I learned a lot. So thank you, viewers, as well, for tuning in. If you can, just let us know what you think. There's a little QR code on your screen. Feel free to scan it and let us know. Give us any feedback for next time. Thank you for watching. And again, thank you, Jess. See you all next time. Thank you.
Thank you.